Welcome back to Mind Diagnosis Lab. This is part 2 of episode 8, Bipolar Disorder, Breaking Down the Highs and Lows. Section 3, Epidemiology and Consequences of Bipolar Disorders. Although bipolar disorders are among the most well-known mental health conditions, they are far less common than major depressive disorder, MDD. According to data from the World Mental Health Survey, a large epidemiological study covering over 61,000 individuals across 11 countries, only 0.6% met the criteria for bipolar I disorder globally. However, this rate increases to about 1% in the United States, indicating regional variability in prevalence. When it comes to bipolar II disorder, prevalence estimates vary but generally fall between 0.4% and 2%, while cyclothymic disorder, a milder chronic form of the condition, is believed to affect approximately 4% of the population. Early onset and gender differences. Bipolar disorders frequently emerge in adolescence or early adulthood, with more than half of individuals reporting onset before the age of 25. This early emergence can significantly disrupt academic, social, and occupational development. Although the overall rates of bipolar disorder are roughly equal in men and women, there are gender-related differences in the experience of the disorder. Women are more likely to experience depressive episodes, while men may more often present with manic or hypomanic symptoms. Recurrence and chronicity. One of the defining features of bipolar disorders is their high rate of recurrence. Over 50% of those with bipolar I disorder experience 4 or more episodes throughout their lives. In fact, a meta-analysis of 8 studies showed that 41% of individuals experienced a recurrence within the first year after their initial episode, and 60% did so within the first 4 years. This indicates a pattern of chronic instability that often requires long-term treatment and management. Comorbid conditions. Bipolar disorders rarely exist in isolation. Roughly 2/3 of individuals with a bipolar diagnosis also meet criteria for an anxiety disorder, and many meet criteria for substance use disorders. These comorbidities can worsen the prognosis, complicate treatment, and increase the risk for hospitalization or suicidal behavior. Occupational and functional impairment. The burden of bipolar disorder is evident in functional outcomes. According to a large community study, less than 15% of people with bipolar disorder were employed full-time in the previous year, a stark contrast to general population statistics. Persistent symptoms were associated with even lower levels of functioning, making it clear that the disorder can be disabling, even between acute episodes. Suicidality. In the World Mental Health Survey, 25% of those with bipolar I disorder had attempted suicide at some point, and more than half reported suicidal ideation in the past year. A long-term national cohort study in Denmark identified bipolar disorder as the psychiatric condition most strongly associated with suicide, even higher than major depression. Life expectancy and medical comorbidities. Bipolar disorder isn't just associated with psychiatric symptoms, it also contributes to shortened life expectancy. People with the condition die, on average, 8.5 to 9 years earlier than the general population. A significant contributor to this elevated mortality is cardiovascular disease, for which the risk is twice as high among those with bipolar disorder. However, the risk is not limited to cardiovascular causes. Studies show higher mortality rates from a wide range of medical conditions. Section 4. Etiology and risk factors of bipolar disorder. Understanding what causes bipolar disorder requires a multi-layered view. It is not the product of one gene, one experience, or one imbalance. Instead, bipolar disorder results from an intricate combination of genetic predisposition, neurochemical disruptions, neuroanatomical changes, and environmental factors, all interacting in complex and dynamic ways. Genetic influences the heritable blueprint. Bipolar disorder has one of the highest heritability estimates among psychological disorders. Studies suggest it is approximately 0.80, meaning 80% of the variance in bipolar disorder within populations can be attributed to genetic factors. But this doesn't mean a person inherits the disorder outright. Rather, they inherit a vulnerability, a set of genetic tendencies that may or may not manifest depending on environmental exposures. Family studies have consistently found higher rates of bipolar disorder among first-degree relatives of individuals with the disorder. For example, children of a parent with bipolar disorder are up to 10 times more likely to develop a mood disorder compared to children in the general population. Twin studies further support the genetic link, with monozygotic twins, who share 100% of their DNA, showing a concordance rate around 60–80%, while dizygotic twins, who share 50%, show rates of about 10–20%. Importantly, the genetic vulnerability is not specific to bipolar disorder. Research shows overlapping genetic risks across various psychiatric conditions, including schizophrenia, major depression, ADHD, and anxiety. Genome-wide association studies, GWAS, have uncovered that many of the same genes implicated in bipolar disorder are also involved in these other conditions. Moreover, bipolar disorder is considered polygenic, meaning many genes, each contributing a small effect, collectively increase the risk. Genes related to dopaminergic, serotonergic, and glutamatergic systems are particularly relevant. Still, researchers are not just searching for the genes themselves, but also trying to understand how these genes are expressed and regulated in real-life contexts. Gene-environment interactions and epigenetics. The latest research emphasizes a gene-environment interaction model. Our environment can switch genes on or off. For instance, someone may carry a genetic risk for bipolar disorder, but whether this risk becomes reality might depend on exposure to early life trauma, chronic stress, or substance use. This is the domain of epigenetics, changes in gene expression caused by mechanisms other than changes in the underlying DNA sequence. Environmental influences like childhood maltreatment or loss of a parent can leave epigenetic marks on DNA that alter how genes operate, potentially for life, and even across generations. One compelling animal study found that nurturing maternal care in rats led to more stress-resilient offspring by altering methylation patterns on genes regulating stress hormones, demonstrating how environment literally rewires biology. Neurobiological factors, brain and chemical systems. Several brain systems are implicated in bipolar disorder, particularly those involving emotion regulation, reward processing, and cognitive control. Neurotransmitter dysregulation plays a central role. Bipolar disorder involves abnormal functioning in neurotransmitters like dopamine, serotonin, and norepinephrine. During manic episodes, increased dopaminergic activity may enhance reward sensitivity and euphoria. During depressive episodes, reduced serotonergic and noradrenergic activity can produce apathy, sadness, and fatigue. Neuroimaging studies reveal that individuals with bipolar disorder often show hyperactivity in the amygdala, the brain's threat detection and emotional reactivity center, reduced volume and activity in the prefrontal cortex, responsible for impulse control, planning, and decision-making, which may explain impaired judgment during manic episodes. Abnormal connectivity between the amygdala and frontal areas, contributing to mood instability. Structural brain differences such as enlarged ventricles, fluid-filled brain cavities, and smaller hippocampal volume have also been observed, though findings vary. These abnormalities are not static. Longitudinal studies show that repeated mood episodes, particularly mania, can lead to progressive neurobiological changes. This has led to the idea that bipolar disorder may be neuroprogressive, a condition that worsens over time if not effectively treated. Sleep and circadian rhythm disruptions. Sleep irregularities are both a symptom and a trigger of bipolar episodes. Many individuals experience decreased need for sleep before a manic episode. Insomnia or hypersomnia during depression. Disruption in circadian rhythms, the body's internal clock, is a key factor. These rhythms regulate mood, hormone release, and energy levels. Research shows that people with bipolar disorder may have abnormalities in melatonin secretion and genes that regulate the circadian system. Even minor disruptions, like jet lag, shift work, or staying up late, can precipitate an episode in vulnerable individuals. This has led to therapies like interpersonal and social rhythm therapy, IPSRT, that focus on stabilizing daily routines and sleep-wake cycles. 5. Psychosocial stressors and life events. Stressful life events are potent risk factors for triggering mood episodes, particularly the first onset of bipolar disorder. Common triggers include loss of a loved one, academic or occupational failure, romantic breakup or divorce, substance abuse. Stress may trigger the onset of a first manic or depressive episode in genetically vulnerable individuals, though its effect seems to diminish over time, a phenomenon known as the kindling effect. Once the brain has had one manic or depressive episode, subsequent episodes may occur with less provocation. High levels of expressed emotion, e.e., criticism, hostility, or over-involvement from family members, have also been linked to increased relapse rates. Thus, family-focused therapy, FFT, and psychoeducation for families are often incorporated into treatment plans. Developmental and socio-cultural factors. Adolescence and early adulthood are critical periods for the emergence of bipolar disorder, suggesting that neurodevelopmental processes, like brain maturation, hormonal shifts, may be involved. Additionally, sociocultural factors may shape the expression of symptoms, treatment-seeking behavior, and even diagnostic biases. For example, African Americans and Hispanic individuals are more likely to be misdiagnosed with schizophrenia when they actually meet criteria for bipolar disorder, due to differences in symptom presentation and clinician biases. Section 6. Treatment and intervention. The treatment of bipolar disorders is multifaceted and often complex, requiring a personalized and long-term management strategy. Effective treatment must target not just the acute symptoms of mania and depression, but also focus on relapse prevention, improving daily functioning, and enhancing quality of life. This section outlines the primary approaches to treatment, including pharmacotherapy, psychosocial interventions, and adjunctive supports, while also addressing challenges in treatment adherence and the importance of coordinated care. Pharmacological interventions. The cornerstone of bipolar treatment medication is the first-line treatment for both bipolar I and bipolar II disorders, particularly during acute manic or depressive episodes. Pharmacotherapy is essential in stabilizing mood, reducing symptom severity, and preventing recurrence. However, the specific medication regimen often varies depending on the subtype of bipolar disorder, phase of illness, individual response, and side effect profile. 1. Mood stabilizers. The gold standard among mood stabilizers is lithium, a naturally occurring salt that has been used for decades. Lithium is effective in treating acute mania and preventing both manic and depressive relapses. Numerous studies support its efficacy, especially in reducing suicidal behavior among individuals with bipolar disorder. Efficacy. Lithium has demonstrated significant prophylactic properties, reducing the risk of mood episode recurrence and suicide. Limitations. Despite its benefits, lithium requires regular blood monitoring due to a narrow therapeutic index. Side effects can include tremors, weight gain, thyroid and kidney dysfunction, and gastrointestinal issues. Some patients may find these side effects intolerable or may be non-compliant with regular blood tests. 2. Anticonvulsants. Several anticonvulsant medications are also used as mood stabilizers. Valproate, Depakote, often used for acute mania and mixed episodes. Carbamazepine, particularly helpful for patients who do not respond to lithium. Lamotrigine, more effective in treating bipolar depression than mania and commonly used for maintenance therapy. 3. Atypical antipsychotics. These medications are often used either alone or in combination with mood stabilizers, especially during acute manic or mixed episodes. Examples include olanzapine, quetiapine, risperidone, aripiprazole. These drugs are effective in controlling psychotic features that may accompany mania and have mood-stabilizing effects themselves. However, they may cause metabolic side effects such as weight gain, diabetes, and elevated cholesterol. 4. Antidepressants. While antidepressants may be used to treat depressive episodes in bipolar disorder, they must be prescribed with caution. Used alone, antidepressants can trigger manic episodes or rapid cycling. They are typically combined with mood stabilizers to reduce the risk of inducing mania. Psychosocial treatments. A critical complement. Although medication plays a central role, psychosocial interventions are indispensable for improving long-term outcomes. These therapies enhance medication adherence, address residual symptoms, teach coping strategies, and support the patient's broader functioning. 1. Cognitive behavioral therapy, CBT. CBT helps patients recognize and modify negative thought patterns and behaviors that contribute to mood instability. It's particularly beneficial in managing depressive symptoms and preventing relapse. 2. Interpersonal and social rhythm therapy, IPSRT. This structured therapy focuses on stabilizing daily routines, particularly sleep, eating, and activity patterns, while also helping patients address interpersonal problems. The rationale is that disruptions in biological rhythms can trigger mood episodes, and restoring regularity can promote mood stability. 3. Family-focused therapy, FFT. Developed specifically for bipolar disorder, FFT educates families about the disorder, teaches communication skills, and supports problem-solving. Families learn to reduce expressed emotion, such as criticism and hostility, which has been linked to relapse. FFT has been especially effective in preventing hospitalization and improving family relationships. 4. Psychoeducation. Teaching patients and families about the nature of bipolar disorder is one of the most effective and essential components of treatment. Psychoeducation covers topics such as recognizing early warning signs of relapse, the importance of medication adherence, managing lifestyle stressors, developing a crisis plan. Let's consider a case example. Claire. In a documented case of a 17-year-old girl named Claire diagnosed with bipolar I disorder, family-focused therapy was added to her medication regimen. The clinician began with psychoeducation, helping Claire and her parents understand her condition. Through structured problem-solving, they developed strategies to respond to suicidal ideation, including safety planning and communication protocols. Eventually, mood monitoring and communication skills were introduced, reinforcing family support and emotional regulation. Claire's outcomes improved over time, highlighting the value of combining psychosocial interventions with medication. Adherence challenges and side effects. Non-adherence to treatment is a significant issue in bipolar disorder. It may stem from side effects of medication, lack of insight into the illness, anosognosia, fear of stigma, beliefs that medication is no longer needed once symptoms remit. To mitigate non-adherence, clinicians should engage in collaborative decision-making. Regular follow-ups are critical. Simplifying medication regimens when possible can help. Providing psychoeducation and support from family or peer groups is crucial. Comprehensive, long-term management. Given the chronic nature of bipolar disorder, treatment must be viewed as a lifelong management plan, not a temporary fix. Treatment goals should include achieving mood stability, enhancing functional capacity, preventing relapse and hospitalization, supporting the patient's autonomy and life goals. This often requires a multidisciplinary approach, involving psychiatrists, psychologists, social workers, family members, and sometimes occupational therapists. The integration of pharmacotherapy, psychotherapy, psychoeducation, and social support is key to achieving optimal outcomes. If you found this episode helpful, consider subscribing for more evidence-based insights into mental health. In our next episode, we'll explore the treatment of mood disorders, breaking down how therapy, medication, and support can make a difference.